Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. So today, I usually do at the end of the month, or at least I try to do at least every quarter, a Top 10 Tuesday. But right now, I've got maybe 4 really good topics for Top 10, so I'm going to save it for Thanksgiving week because I've got some good ones that we'll do next month. But I wanted to talk about some of the things that I'm seeing again with my audits and sometimes during some educational sessions that I'm doing. And that is physicians that are trying to add a lot of the new reimbursable G codes to services where, providers are saying, well, I want to get paid for, some of those services. I mean, for example, the annual well visits, the G0438 to G0439. And they ask a lot of questions like, am I eligible to do that? So first of all, provider eligibility on G codes, and there's so many. There are ones for behavioral health, for depression screening. There's just so many. It's vast. But the service must be performed first by a provider who is eligible to bill for that specific service under Medicare. So it's typically any physician, any specialty, but it's something that you do on a regular basis. And remember, if you aren't, like, for example, on the annual well visits, if you aren't a primary care provider or an internal medicine or general practitioner, it wouldn't be appropriate to bill it if you're an orthopedic surgeon or whatever. So it's basically you're saying that you are taking care of that patient's risk factor reduction overall. Non-physician practitioners like PAs, nurse practitioners, can also bill for these services. Anyone who can bill directly to Medicare. And on the FQHC side, rural health clinics, remember, they are paid for, it doesn't matter what they do in a day, they're paid one service. Now, on the cost sheet, can you report it? Yes, but you won't get additional payment for that. Now, Medicare enrollment, so as a provider organization to bill for any of these G codes, you must be properly enrolled with Medicare to submit certain claims and also for certain programs. So for things like the Medicare Diabetes Prevention Program, the organization must be separately enrolled as an MDPP supplier, even if they're already enrolled as another provider type. So you really make sure you're taking a look at that fact sheet. And then billing is specific to certain G codes. So you have to know the frequency guideline. You have to understand what you're covering. And I try to get people not to Google everything, but you can absolutely Google annual well visit, and it'll bring you up the Medicare guidelines and the PDF they have showing you the difference not only between the initial, the subsequent, but also something we call the IPPE, which is the initial preventative physical exam, G0402, and that's just once per lifetime for a Medicare patient. Basically, they call it a welcome to Medicare visit. Now, service and documentation, the provider must deliver the services as described by the G code and maintain the necessary documentation to support the claim. If you try to build some of these G codes, because remember, they're G, we're watching you, they're specific to Medicare. If you bill a G code to a commercial plan, it will likely be denied unless you have something in writing saying that they will cover it. So there are a lot of different things when it comes to those G codes that, they range from G0008 to G9999. Some are payable, while others are non-payable, and they call them functional codes, where it's more informational, and you just want to make sure that you're not overstating some of those services. So, for example, G0101, what is that? Well, G0101, that is when you're doing a PAP and pelvic on a Medicare female patient, and the Q0091 is when you're sending out for the pap smear as well. Now, remember, if a patient's had a hysterectomy, you're not really doing a pap smear or breast exam or a pelvic. So remember some things like that. I see that every once in a while, and that's kind of crazy as well. Now, what about, patients that I've seen a code G0463. Was implemented for Medicare to report hospital outpatient clinic visits for assessment and management. So this is primarily for Medicare when a patient isn't in their office, but they were sent to the hospital as an outpatient to be assessed. Sometimes I'll see that with infusion centers, and it's not technically a facility fee, but it is under the ambulatory payment classification. So always keep those things in mind as well. Now, what about with some of the things that Medicare has with G codes for depression screening? I'm seeing that all the time. It doesn't seem to matter what the specialty physician is, but let's talk about that for a second. So we've got code G0444, annual depression screening, 15 minutes. And then also for annual alcohol misuse screening up to 15 minutes, we've got G0442. Now, you'll notice the first one I mentioned on the annual depression screening, 15 minutes, and the alcohol misuse screening was up to 15 minutes. So you have to have at least 8 minutes on the alcohol screening code, but you have to have 15 minutes on the other one. Always read specific information and definition of the code so you know what you are providing. And these are also, tied to specific quality initiatives as well. Typically, they're going to want to be seen by their primary care doctor or the provider that's following them for everything. But be careful when you are giving a patient a screening where you're not following the rules. Annual depression screening says that the patient doesn't have a current diagnosis of depression, but that there is some factor where the provider feels that it was appropriate to screen the patient today. You can't just do it as a blanket screening. First of all, patients will not be happy with you. And secondly, it's not the definition of the code. There has to be some kind of, and I'll call it a trigger. Same thing where it is annual alcohol misuse screening. So is the patient basically telling you they're having some issues with, maybe they drink a little bit too much. You don't feel that it's a problem, but it could end up as a problem. That's when that would be appropriate to now provide a screening on that patient. You've got to be a little bit careful because when you are dealing with some of the screening codes, it can come with a out of pocket for a patient. Most don't, and so patients don't tend to mind when they don't have a share of cost. But because it's also submitted to an insurance company and it is now on their health record, patients want to know what the heck it is you're actually doing. So there are different screening codes for that. So G0010 for Hep B vaccine administration. Now, if you're doing the Hep B administration and you also have a conversation with the patient about that, you get to code that in addition as well. And there's also some codes that were given that were helpful during the pandemic, but that are no longer services that you can receive. So, for example, during the pandemic, the code that our rural health clinics and the FQHCs were allowed to report for virtual care, in addition to the what's on the cost sheet. And it's not for anything extra, it's just that you administered the care virtually, so you were available for them, was G2025. That was available through September 30th, but then with the shutdown of the government currently, it's no longer being paid. So that was supposed to go through December 31st, 2025. Unfortunately, again, with the shutdown, that's a problem. Now, quality reporting and incentive programs, we do have CPT codes that talk about, for example, smoking cessation. But when you are trying to do smoking cessation counseling as part of a preventative service, and doctors use it to show they are helping the patients quit smoking, even if the patient isn't necessarily acknowledging that they want to be part of that or they want to quit, the G8427 is appropriate. But if you're trying to build the CPT codes for that, the non-G codes, 99403, 99406, those codes in there, then those are a problem because those have time base. Those are also tied to the patient agreeing to quit smoking. So know the difference between the screenings versus non-screenings. There is a code for prostate cancer screening via digital rectal exam. So if a doctor performs this screening, they would use G0102 to get paid for it. Now, I saw a doctor trying to use that code and the patient deferred their rectal exam. Yeah, if they're not doing it, you can't code for it. So be careful of that as well, because I am seeing, again, some G codes that were not appropriate when it comes to billing and making sure that you're getting paid for that if it's not part of that service. Now, or if you don't meet the criteria of the code. Now, the add-on code G2211, which I know we all know what that is, in addition to an office or other outpatient E&M-based code, or it can be added to an annual well visit, vaccine administration, or another preventative service when furnished in the office or outpatient setting. That's a complexity code. That means that you're agreeing to provide all services for that patient and deal with all, and I keep saying all because that's part of the descriptor, all concerns and outside sources and everything that patient needs when you're making your medical judgment. So if that's not the type of visit it is today, then that's not something you should add, automatically to your services. So there's a lot of different things. I mean, we even get into advanced primary care management services. We call them APCM. And, those are helpful. They're just like the chronic care management, so but these codes are G0556 to G0558 instead of CPT codes. But when you look at these codes, you have to be cognitive of the fact that they do include anything that you read about the primary care management, TCM, or chronic care management codes. They don't have time thresholds, but you still have to include all of the information and all of the resources and services that is part of the management, the care management codes. So sometimes I'll see, everyone's like, we're going to do this for everyone. No, you have to also look at how many chronic conditions are you managing. So it's really part of what you are doing, what can be tracked as you are doing, what you can support. And sometimes we do see some of these services a little bit inappropriate, and we just don't want you to get involved in that. Now, one of the other things that it can be pretty interesting when I see this on a code is that when I see somebody trying to bill for the behavioral management screening or the mental health screening, if you're not somebody that's dealing with that in your specialty, then that is going to be a problem if it comes back and says, is this something you started doing? I mean, there's a lot of dentists out there, for example, that are billing for services that are now being questioned. And so you just don't want to be billing something just to bill for it. Remember, if you bill any services that are screening, and then the patient actually, after that screening, you're looking for something, and they need to have now a psychologist or a clinical social worker or possibly a marriage and families therapist or a mental health counselor, you have to provide that for them, and you also have to be a part of the follow-up and the treatment plan. And so do you want to get involved in that? It doesn't just stop at the G-code screening. So that's important to understand. CMS is also allowing for a new outpatient add-on code via two-way audio and video. Now this, I don't know if this survived the shutdown, but this was for initiation of treatment with methadone. I don't think it did. But G2076, and that has to be audio and video. So take a look at that if you're somebody who does the actually, that probably did survive it because this is part of the opioid treatment program, and on telehealth, the substance abuse SUD treatment is still covered under telehealth. So that actually probably did, now that I come to think of it. So there's a lot of G codes. You can actually Google all of them and see if you are qualified or if it's something that your provider would provide and would be interested in providing, and the follow-up and all the management that goes with that should that one of those screenings find something on it. So always keep that in mind when you're billing a screening, that you don't want to bill it just because it says you can, and you don't want to bill it if it's not appropriate. So always just use caution when you're sending anything, because bottom line, it has to be medically necessary to bill for anything, even a screening. Why are you doing it? Why do you think this patient needs screening? Think about a GI patient. They cover screenings for patients for colon cancer over 45 now. Why? Well, because statistically it's shown that it's mostly men over 45 and women over 50 are susceptible to high rates of colon cancer. Well, that's a rule. That's why they now cover that without an out-of-pocket to the patient. Same with other G codes and other screening codes. when they allow it, they're saying that, well, that's because our clinical history, our clinical assessments, and information that we have found on published guidance has said that this is appropriate for this patient population. So you have to follow those rules and those guidelines to be able to report that. Okay, well, that is it for me today. I hope the shutdown is ended before our next episode. We just had our 12th vote in Congress today, the day I'm recording, and it was no again. Even a vote just to pay our air traffic control, our military, and our essential government workers was shot down by and I'm going to say it, the Democrat side. Remember, we have a majority in the Republican Senate, which is 53, but you need 60 to be able to filibuster, to be able to pass budget and things like that, and pass any kind of spending bills. And so we need 7 Democrats, and we've got 1 or 2. That's it. So until that gets passed, and they have demands that are just something that's never going to happen. So just keep that in mind, that this could go on longer than we anticipated. I hope not, because right now the full shutdown has gone on longer than it ever has. We did have in 2000 and I think it was 18, I think we had a 32-day, but it was partial shutdown for most of it. So keep that in mind. I hope it's better news next time we get together, and it's constantly clock watching. Also, for those of you that are still thinking about telehealth, it's still shut down. There's nothing that will allow your patient to be seen at home under the traditional Medicare payer. So unless they are substance use disorder, mental behavioral health, or end-stage renal disease clinical monthly assessments, that's it. No other diagnoses, no other services, even on the approved telehealth list, are covered for them being in their home. So keep that in mind during the shutdown, and try not to get around it. I do see too many practices saying, well, we're going to bill it this way. You can't pretend a patient was in your office if they weren't. So do not try to get around that. All right, everyone. I hope you have a good rest of your week. Make it a great day, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.